Hello everyone, welcome to Neobiotech International Virtual Seminar. Thank you for attending this webinar and my name is Gabriel Lee. I'm gonna be the host for today's webinar. We are doing webinars on every Wednesday as you can see, mostly in English, but sometimes other languages are available. Please contact your local sales reps for detailed information and registration. Now we have 2 webinars left for this month, today and next week, and we're gonna learn about VARO guide system. In October, we'll have 3 webinars, so please don't forget early registration. Languages for 21st day will be Spanish, and for 28th day, it will be Russian. So do not miss them if we are speaking those languages. For today's webinar, Dr. Park from USA will speak about VARO Guide Chapter 1, Why VARO? For 1 hour, he will give his idea and knowledge about this new system. Please use chat button to communicate with me any issues other than topic. We'll have a Q&A session after lecture, so please submit your question through Q&A button. Speaker may not answer for all questions because we have limited time to take all questions. If you have more questions or anything for discussion, you can contact Neobiotech website or Facebook page or by email address. Okay, now let's have Dr. Park to start. Please welcome Dr. Park. Hello, doctor. How are you?
How are you, Gabriel? Thanks for your kind introduction and then great instruction. How are you doing today?
I'm very good. Thank you very much for asking.
All right. Then let me start the lecture today. Okay, so let me share my lecture altogether, slide altogether. Right. Okay. Hold on. Okay. Hello, doctors. I'm so happy to have a chance to meet you, all of you. I'm in California, Los Angeles, California right now, and I just finished seeing my patient at GAO Education Center in USA, and then please excuse my appearance, right? So I am having a chance to meet you, all of you right now in the GAO USA Education Centers. So today we're going to talk about the why VARO, V-A-R-O, VARO guide systems. Today, actually, I'm going to more focus on the clinical limitation of conventional CAD/CAM guided implant surgery systems. So then I'm going to discuss what is the problem and then how can we overcome it, and then what is the limitation. And then also I'm going to share my humble knowledge and experience about VARO guide as a breakthrough solution to overcome the limitation of CAD/CAM, conventional CAD/CAM guided systems. I used to teach in UCLA in prosthodontics about 15 years, and then last year I joined the Neobiotech as a clinical research and development, and also currently I'm a president of the Neobiotech USA, and also I'm the director of the GAO USA Education Centers. Well, why do I talk about the VARO guide or any CAD/CAM system? The main reason is when I started the professor career, I used to work a lot with different companies to develop the guided system. That is about 12 years ago, and then I used to work with Noble Biocare, and then I joined those beta tests and then clinical protocol of those things. Since I'm a prosthodontist, many companies ask my opinion because that is kind of partial denture or complete denture, right? The guide itself, and how can we use those prosthetic information into the surgical planning, those things. That was the beginning of my relation with the guide system. And then about 7 years ago, now 8 years ago, Neobiotech contacted me, and then I used to work together with the Dr. Her to develop the new system, and then also the clinical beta test, and then the develop of the protocols, right? So let's get to business. So far, we have so many CAD/CAM guided system, right? Each company claim that their system is beautiful, accurate, and then very safe, right? It's been more than about 10 years, right? This is for the full mouse case or only the pilot drill. Now we have all those, the dynamic guide system, and also we have those milling guide system. And also, of course, we have a Neobiotech Navi guide system. So there's just so many CAD/CAM based implant guided surgery systems. But question is this: it has been more than 10 years since CAD/CAM guided surgery system was introduced to our practice. But question is, where are we now, right? Did we improved a lot? So now can we trust our guide 100%, right? Unfortunately, many of my friends, they bought those guide systems with different companies, and then they use a couple of times, and then they put those guide systems into their drawer. Still, they advertise their clinic as a digital implant surgery. However, they hardly use it. But recently, we have a more uh, motivation, and also we have more knowledge and technique, then we can overcome a little bit more and more doctors are using the CAD/CAM guided system. However, I really want to know, and I really want to share with you guys the dark side of those guided system, right? So nobody going to told me before when I started those research and clinical trial, and then those many, the slide is based on my experience, of course, based on my failures. So I want to share with you what I know about the clinical complication and the clinical limitation of those CAD/CAM guide system first. So I'm gonna go with you guys very quickly about the literature review to understand the efficacy or accuracy of the guide system. We need to discuss about how to measure the accuracy guide systems, right? And then I'm gonna go with you about the workflow and the error of the guide. And then also I'm going to discuss with you shortly about why it is important for us as a dentist to do the planning and then the surgery ourselves. So I'm gonna discuss about very quickly, briefly. Now, let's talk about how to measure the accuracy of the guide system. As you can see on the left slide, you can see those green one, that is what we planned. And then those pink one is what we placed. So apparently there's a discrepancy, right? So there's a vertical discrepancy like BFE and VA, and also there's a linear discrepancy or horizontal discrepancy LP or LA. And also most important one in clinical situation is the angular difference, angular discrepancy, that is A or alpha. So on the middle one, as you can see, this is what I wanted to place, but it ended up a pink one. So now in this case, the angular discrepancy is 9 degrees, and then entry point lateral deviation is 1 millimeters. How about the other one? This is what I wanted, but this is actually what placed. So in this case, those angular discrepancy is 19 degrees. The entry point lateral deviation is 1.5 millimeters. So based on my humble experience, those linear discrepancy is not a big deal, right? Relatively. However, those angular discrepancy makes me smile or makes me cry, right? This is really important. And then why I'm talking about this? Because many guide system, actually all guide system has an issue with those alpha. So I want you to keep in mind, decreasing those alpha is really critical. The angular discrepancy is really critical to get the successful clinical outcomes. So to measure the accuracy of those guide system, first we planned it. Second, we actually placed it using the guide. And then those two images we need to superimpose together. And then those two images, and we can measure the discrepancy. So in this case, middle picture is showing you that digitally how it placed, and then also the pink one is where we placed. So you can see those discrepancy. And of course, in the analog way is once placed the implant, we take the impression, right? And then while we make the a cast, and then we can compare the accuracy one to one. Or sometimes we can put those scan body on top of it, and then intraorally we scan it, and then we develop those three-dimensional image, and then we're gonna compare, superimpose what we planned, and then what we placed. We can compare with that one too. However, when we measure the accuracy of those guide systems, what I want you to understand is that is also depend on the geometrical accuracy of the CBCT that they took. And also that depend on the quality of the CBCT images of all those images. And also geometrical accuracy of intraoral scanning images. And also more important one is accuracy of the superimposition. Because we superimpose, we merge those three-dimensional images together, right? So it needs to be perfectly superimposed, right? That is also very important. And then so the accuracy of measuring method is also depend on those things, right? This is kind of superimposed. It's not the perfect one, but it seems okay. But actually in the scientific way, there's quite a big error in it. So when I look at those article about the accuracy of those currently available guide system, right? This article went over 2,359 article, and then they pick up those 24 accuracy studies, right? So first one, what I found is when we compare freehand versus full guided surgery, definitely entry point is freehand is 1.38, full guide is 0.78, apex difference is 1.74 or 1.408. Angular is 5.3 discrepancy with the freehand. However, full guide is 2.57. So based on these numbers, and as we expected, free-handed is not that great, right? In other words, full guided system is much, much better than freehand in terms of accuracy. Yeah, I can buy it. But when I look at the full guided system, within the full guided surgical result, and then the average of those discrepancies, entry point is 0.9 millimeters, apex is 1.29 millimeter, angular 3.65. Then what they're saying is tooth support guide is much, much better than mucosa or bone supported one. And then flapless surgery guide system is much better than flap raised one, right? Alrighty. But what really matters, what really bothers me is this. Based on this article, this meta-analysis article, what they found is among those full guided systems, the entry point average is 1.12 millimeters. However, the maximum error is about 4.5 millimeters. Also, apex point is 1.39 is average. However, max was 7.1 millimeters. And then also angular average is 3.89 degree. However, the maximum error can be 21.16 degrees. You remember the pictures that really badly placed one? That is a 19 degrees discrepancies. But how it is possible to have a 21 degree angular discrepancy, even though we are using the full guided surgery, right? How is it possible, right? I didn't understand, but actually there is plenty of the reason why that happened. Maybe you can read these numbers and I'm going to belong to the average. So we may believe, we hope that our surgery result is follow those averages. But unfortunately, when we see the patient every day, maybe 1 out of 100 patients, right? Maybe 2 out of 200 patients may have those maximum errors. What does that mean is if the entry point is 1.12 millimeters average, but if we are in the bad luck in that situation, then your implant going to be placed about 4.5 millimeter away from your point, your original position. So that means it's going to be very catastrophic, the result, right? The question is, how is it possible, right? Let me share with that reason behind it. So to do that, let me go over the general workflow of CAD/CAM guided implant surgery. First, we usually took the CBCT, right? We must take the CBCT. And then if we have an intraoral scanner, we use an intraoral scanning. If we don't have an intraoral scanner, then we take the impression with the PBS silicone and we pour the stone and we make the model and then we do the extraoral scanning, right? So basically, we create the CBCT, we create those the um, DICOM file, right? That is about the bone, and we create the STL file that is outside of the bone and gum and tooth, right? Through those scanning. Once the CBCT and those two scanning is done, then we are merging. We merge those the DICOM file and the STL file, but both of them are three-dimensional. So those three-dimensional images need to be perfectly superimposed, right? Once they're perfectly superimposed, then we begin to do the planning. So we do the virtual surgery and we do the virtual restoration. Based on our virtual surgery and restoration, then we do the 3D printing or sometimes we do the milling. So usually we make the guide using the 3D printer or temporary crown with 3D printer. And also we're using the temporary final crown with those milling machine, right? Once that is done, once guide is ready, then we're going to do the surgery in our clinics, right? That is a kind of general workflow of those conventional CAD/CAM based implant guided surgery. Now, let's look at the CBCT. I know you paid a lot of money for your CBCT machine, and then you just believe your CBCT is always accurate. Is it really true? One thing we have to keep in mind is when patient took the CBCT, the scanning time is about around 10 or 12 seconds, right? Patient moves. Average patient move about 1.5 millimeter, especially when they breathe, they move about 6 millimeters. So usually 1 out of 5 patient move, right? In the middle picture, you can see that you can see those double images, right? That means patient moves. So if we didn't catch those movement, and then we cannot make the proper guide system or proper virtual surgery because merging is not possible. And also in the occlusal view, you can see those two lines. That means patient move this way, and then you can see that which one is the actual tooth outlines, right? So those patient movement we have to keep in mind. And also in this day, many of our patients has already implant, right? And also they have a zirconia crown or amalgam or gold crown, a lot of restoration in it, especially when those the X-ray photon hit those metal, including zirconia, it causes significant compromised radiographic imaging. As you can see over here, due to the beam hardening, motion, and then edge effect and scattering noise, right? In the middle picture, you can see those two white dot circle. That is an existing implant, right? Once those the X-ray photon hit it, and then you can see a lot of the sun ray over here. Those the ray basically compromise the images. Now the images look very dirty, a lot of noise in it. Also on your right side, on the top part, there is a little ring circled 3 dot, right? However, once X-ray hit those metal, and then the image you're going to see on your CBCT going to be on the bottom one. So ring is not the ring anymore. Ring looks like tire, right? 3 dot is not the dot anymore. Those 3 dot all connected. It looks like triangular. So we need to understand that even though we bought a very expensive CBCT, and then patient can move, they're gonna compromise our image. Also, due to those the backscattering metal artifact, and then our image is in a really great shape. So to make the guide, or to make the digital prosthetics, right, we need to have a good ingredient. However, those ingredients are already compromised, then we cannot expect the proper outcomes, right? Now let's look at more clearly. This one, as you can see on the yellow line, is the result of the model scanning. So now I try to merging it. So I'm using the Implant Studio and automatically then going to merge. So my STL file from my cast external scanning, and then also you can see those CBCT DICOM file. They merged it automatically. It looks fine. But at the tip, I'm magnified a little bit, and you can see those, my yellow line is slightly inside of the white, right, portion. So I'm not quite so sure my yellow line is really matched to the outline of the tooth or not. If I magnify a little bit more, then my yellow line is arbitrarily positioned, right? It's not in, it's inside, but still I cannot clearly see where my crown ended because of the bad contrast of those CBCT, right? So I cannot tell where my crown ended. So contrast means that black is black, white is white. So it is a characteristic that we can tell which one is air, which one is tooth, which one is nerve, which one is bone, right? If your CBCT has a very bad function or bad poor contrast, and then it ended up like that, I magnified a little bit more. Now you can see that it is totally arbitrary. So if you are merging like this, and then already we have a huge digital errors that without our recognition. So this is very important no matter what system you are using it. Make sure you have a good CBCT images and quality. That is really critical. And also let's talk about the intraoral scanner. Nowadays, a lot of companies claim that their intraoral scanner is much accurate and faster and great. Yes. In this article, what they're saying is if we do the intraoral scanning for the single tooth or linear straight line, that is fine. So that is less than 100 micrometers error, so that is clinically acceptable. However, if we do the full arch or if we have a curvilinear situation, for example, if you scan only premolar and molar, most of the time that is great, very accurate. However, if you scan molar and canine central incisor, when you have those curvature, then it's gonna create the error. And then if you do the cross arch and another canine, it's going to cause more error on it. So in that case, the error is more than 100 micrometers, right? That is not clinically acceptable, right? So keep in mind. So intraoral scanner, there is a clear limitation on it. So our CBCT has some issue, possible issue, and the intraoral scanner, if you do the full arch, and then there is also possible error in it. And those two images, three-dimensional image, we merge together, it's going to have a more problem later on. Now, this one is an interesting article. What they do is they're using the same intraoral scanner. So first one is they do the intraoral scanning in patient's mouth. Second one is the same patient, they took the silicone impression, and then with the same intraoral scanner, they do the extraoral scanning, and then they compare the accuracy. What they found is intraoral scanning result is less accurate than extraoral result, even though it's the same patient and the same machine. So what they claim that is because of the moisture or saliva control, that is a main issue. Most of our intraoral scanner is based on the pictures, right? When they scanned it, they took 100 or thousands pictures, and then they just the composite together and they create the three-dimensional shape. But when those saliva slightly cover the tooth or gum or any junction between it, and the light reflection is different, and then it's gonna cause an error too, right? So previously, about 10 years ago, when we do the intraoral scanning, we put some little powder in patient's mouth, dry area, and put some powder as thin as possible, as one layer as possible when we scan it. But nowadays, no companies claim that they need to use a powder. But one thing you have to keep in mind is when you are using the intraoral scanner, make sure you dry very well. So the way I do in my clinic is with my assistant, I retract our tooth, and then when my assistant is keep drying air on those tooth, and I scanning it, right? The moisture is just something, saliva control is a really big issue, keep in mind. So now, we discussed about some issue about the CBCT images and intraoral scanning images. Now those two images, let's say those two images really great, then now those two images need to be merging, right? We need to superimpose, right? Then what can be happen during that time? And this is my real case, and then on the left corner, you can see white model, that is from the CBCT images, right? That is DICOM file, reconstructed 3D images, right? And on the right side, the golden color is the STL image of the model itself. So now I have to merge together, but apparently they're not in the same shape, right? The main reason is CBCT, we get this image, shoot the X-ray photon, and then we see those results, right? And then also external scanning, intraoral scanning, we put the light on it, and then we take the pictures, and then we make three-dimensional images. So physically, from the very beginning, the way did get those three-dimensional images totally different. That's why sometimes there are gonna be some difference too. And then also the compromisation too. In this case, when I try to merge together, as you can see, the yellow line is from the model cast, and then the white one is basically the CBCT images, and then you can see there is no match at all, right? So your CBCT image and then your STL file from the cast doesn't match. Then question is which line we have to follow. There's no way we can do it. But sometimes the lab tech didn't pay attention to it, they just made it, right? In that case, it's gonna create the huge errors. So for example, this case, tooth number 11 looks matching the margin pretty good. However, same case, tooth number 7 is totally out of the tooth position. So when I merge the better on the tooth number 7, then tooth number 11 going to be out of the outline. So you're gonna see so situation. In this case, what should we do? How can we know that my CBCT is wrong or whether my impression is wrong or my model is wrong? Unfortunately, I had no choice but to call my patient again and take the CBCT again and take the impression again. So this is the second with the same patients. So this one is a little bit better, right? And then when we merge it together, the merging is still much better than before. However, if you look at closely, the yellow line and then those the CBCT X-ray image is not perfectly matched, right? Because of those physical characteristics is different, and also because of that backscattering on those crown, they're going to compromise the outline of those CBCT images, right? So those are built-in problem. Now this one I want to share with you some case. What I did is I took the CBCT and also intentionally I did the intraoral scanner for the full mouth in the lower, right? So let me share those video clip with you guys. As I move from the right to the left, and then you can see that even the tip of the tooth, right, is huge error on it when I move more and more. As you can see, outline is totally out of the merging, right? So in this case, intraoral scanning is wrong, maybe. Well, my impression, the CBCT is wrong, maybe, right? That is quite a difficult question, right? It can be CBCT errors. Well, if I took the impression and then put the model, then it can be the impression error or model work error or my STL error too. How can we tell? No way. So this is why it is important that you have to maintain, right? And you have to calibrate your CBCT as close as possible. And then every 6 months, I strongly recommend you to maintain your CBCT. At least we can eliminate the possible factor for the wrong CBCT in terms of those contrast issue or the dimensional accuracy issues, right? And also make sure your patient doesn't move during the CBCT taken, right? Now, once we jump those merging and planning issues, then let's look at those 3D printing or milling issues, right? So now you can see in the middle one, this is a guide system, they are rocking over there. So even though they're rocking on the model itself, that means that when I place the implant in patient's mouth, it can go left side a little bit, while next you're going to right side a little bit. It can be seesaw and rocking there too. it's going to be a huge problem. But why this is happen? The main issue is the tolerance. All the 3D printer is not equal. Sometimes they're using the CNC machine, or sometimes they're using the all different of the 3D printing. That 3D printing depend on the machine and depend on also the material too, and also depend on the lab technician's experience and then technique. It's a very technique sensitive. So even though on the monitor, on the computer, I want to 3D printing 1 centimeter by 1 centimeter by 1 centimeter cubic, it doesn't necessarily my 3D printer create those exact 1 by 1 by 1 cubic at all. So there is always need a calibration depend on the machine and depend on the material. So I want you to keep in mind, the 3D printer, the result is also need a huge calibration. It's not always accurate. You have to keep in mind, right? Now, more important one is this. Let's say we jump all those hurdles and then we create those guide and then we are about to place the implant, right? But I want you to understand the concept of the tolerance. Tolerance is a permissible limit in physical dimension. So we have a male part and we have a female part. If they are exactly 5 millimeters diameter of the circular shape, and then if they are exactly 5 and 5 millimeter, it will not be connected, right? That means our female part need to be a little bit larger, or my male part a little bit smaller. So we need a little gap. Same thing. When we put the guide in patient's mouth, patient's tooth, we need a little gap so then our guide is going to sit on the tooth properly, right? And also when we put those drill on the sleeve, we need a little gap, right? That is a tolerance. In that case, we have a small tolerance, we have a large tolerance. If you have a small tolerance, it is more accurate. The problem is clinically, when you place the drill on the hole, it is not easy to find out your path of insertion, not easy, right? If we make the tolerance too big, then your accuracy is going to be down and then your drill can be wobbled, right? So this is when about 7 years ago when I started to research and then develop those systems. This is what I dreamed about. When I get those beta tests, hey, there's a hole, there's a drill, then I can put it like that and then problem solved. So easy and clean and safe. But in reality, it's not like that. Because of the tolerance, my drill can be go like that. My drill can be go like that. So it ended up, even though I make the hole, make the osteotomy through the hole, it can be create those huge errors. It's a built-in errors, right? So nowadays, Neobiotech, we create those early engaging system, and then we do a lot of trial error, and then the tolerance for those metal sleeve is about 49 micrometers, or 51 micrometers is clinically acceptable. So even though now, after 10 years now, still we have those tolerance, yes, because of the tolerance, we have those little gap, right? That means that is a built-in errors. Even though you follow everything perfectly, but still you can have those errors. Excuse me. Let me share this article with you. This is a purely mathematical calculation. So this article, excuse me, this article just showing you that how much error possibly happen if I'm using those guide system. They look at the sleeve length and also they look at the offset and also they look at the total length. So and also they look at the clearance. The clearance is basically tolerance, right? The gap between drill and those sleeve, right? What they found is those three factors really important, right? When we look at more closely, right? Then the bottom line is this. If the clearance is more, the bigger the clearance, we have a more error. If we have a longer length, right, from the beginning, from the top to the bottom, then we have a more errors, right? If your sleeve length, right, is shorter, then we have a more errors. So what they found is the maximum error can be built-in error if we're using the 4 millimeter of the sleeve length, right? Then apex can be 2.8 millimeter error and entry point can be 1.5 millimeter error. Angular can be 5.9 millimeter errors. But good thing is vertically there is a very little errors. So this number is showing you that if goes everything perfectly, however, only because of the tolerance and the total length of the implant, there is a built-in error. There's a possible error that this error can be happen in our daily practice. Just keep in mind. So that is why tolerance is a big issue. If we make the small tolerance, great, but the dentist, like clinician, we cannot put in the drill in the really right position intraorally, right? And also there is something the quality control issue too. So in this case like that, if we have a slope situation like immediate placement or anterior case, then this is what we dreamed about it. However, because of the tolerance, once we hit it, we go in there, and then when I push it, going there, and then when I push my drill a little bit harder, then as you can see, whole guide can be moved. So in this case, guide gonna be moved a little bit because of the gap between guide and tooth. And also my drill is a little bit tilted because of the gap between my drill and sleeve, right? This is going to be happen even though you're using the guide. So this is my case. This is about 8 years ago. This is what I planned. Once I pull out the tooth, I put some bone grafts over there, and then 4 months later, this is how I planned it, and this is how I ended it, right? Because at that time, I have no idea about those tolerance issues, right? There's a hole and drill. If I just follow the hole, everything is fine. That is not true at all. Now, how to solve these issues? Right now, nowadays Neobiotech recreate those the bone flattening drill. So before we make the first point drill, we make those bone a little bit flat, and then we can put those the point drill, and then there's a little slippery. Then we can start move on, right? This is one of the good way. However, there's still issue with the tolerance. How about this? When we pulled out the tooth and then I want to place implants immediately, and then many of my friend told me using the septal bone, right? Make the fissure bone, make a little bit nice, and then maximize your septal bone as much as possible. Well, this is what I dreamed about it, even though I'm using the guide, right? But many times it going ended up like that. This dramatic change can be possible, yes. You remember that the angulation difference can be about more than 20 degree, 25 degree. Can be happen if we didn't pay attention to the guide movement. In that case, we just flattening those septa bone, and then we place the implant. We do the pointed drill is much better. So this is one good way that Neobiotech created it, but still we have some issue with those the tolerance, right? How about the anterior case, right? When we have a very thin layer of the buccal plate, we dreamed about my implant can be placed like that. Everything is perfect, put some bone graft on the buccal area, then everything is fine. But in reality, maybe many of you already experienced it, right? It goes always buccally position if you didn't pay attention to it, right? Because when we place the implant, we usually do the under osteotomy. So our osteotomy is a diameter is smaller than actual implant diameter, right? So when we place the implant, there's going to be a lot of resistance from the palatal side. So it ended up pushing our implant to the buccally. If you didn't pay attention to it, it's going to be totally like this out of those bone like that. That is possible, right? This is my old clinical case. It ended up like that. Right? Once this has happened, it's a big headache, right? Even though we are using the guide, this thing can be happen. Yes, it can be happen, right? Right. So how about those the dynamic guide, right? So nowadays those dynamic guide is X guide. They claimed that right. This is a real-time guiding system, right? But the basic protocol is this: when patient comes in, we make those marker, and then we take the CBC together. And then we're using those tracker. As you can see, one tracker is on the drill, the other tracker is on the marker. And then there's a big two camera on top of it. And then those two camera give you the position, three-dimensional position of your drill, and then those the jaw, right, based on the X-ray, based on the CBC image, and then you can see the real-time images, right? The problem is this, even though it looks like real time, I'm looking at the bone, I'm looking at my drill position, everything is fine, but keep in mind, everything is depend on the CBCT and also intraoral positional jig, right? So bottom line is exact same limitation of the static guide in terms of the CBCT image, and then heavily depend on the quality of the CBCT and restoration of the jig, as I told you before. And also preparation is quite difficult. Assembling is some issue over there. And also if everything goes very well, however, there is no physical guide. So it is like really GPS or navigator of your car. Sometimes your navigator tells you that turn left, but you missed it. Oh, I have to turn left, but you just go straight it, and then your navigator tell you that hey, make a U-turn, right? Make a U-turn. But in the clinical situation, when you have to make the left turn, you have to make the left turn, right? So those GPS, the type of the situate the guide is quite difficult in terms of for the beginners. So overall, limitation of the current guide system is if we're using the static guide, right, then we need a multi-visit, right? Patient comes in, take the impression CBCT, and next visit we do the guide surgery what we have to try in. And usually the fabrication time is about 5-10 business days, right? And then there's a shipping day too, right? And then once it's made, once the lab technician send you back, and then you try in patient's mouth, it doesn't fit, it is mostly impossible to adjust it, right? You cannot adjust or you cannot correct, you cannot fix those the guide once made, once 3D printed out. You grind inside and then you make sure it's fit in, but how can you be so sure that that guide is exact position than you planned, right? Grinding the inside is easy, but now you're losing the whole accuracies, right? So the good, really important part is once the guide is made and then once you deliver to you and then your patient is on the chair and you try in your guide, it doesn't fit, end of the story, right? Then you have to cancel the surgery and you have to make the new impression or new CBCT and then make the new guide. That is really the bad part, right? How about the dynamic guide, right? The accuracy is totally depend on the surgeon and also the limitation related to the CBCT is still the same. And then also there is no physical guide, right? Basically, it is just a GPS. There's some issue both of them. Now, with this, the limitation, what is a better way to have a better guide for the clinician like you and me, right? I wanted to do the immediate chairside guide planning. I do not want to send my laptop, right? If the software is easy, I want to do the planning, right? Maybe 10 minutes, 20 minutes, right? Then I can see the patients, right? And also I want to fabricate the guide in the chairside, maybe 1 hour, 20 minutes, right? So if I can do it, that'll be great. And also most important thing is I want to fix it. Yeah, I made it, it's not really fit very well, then I want to correct it. And also I want, if it needed, I want to remake in the chair side, right? Immediate chair side correction and remake, right? And also, as I told you before, we know that tolerance is needed, but I really want to decrease those tolerance as small as possible, right? So if there's a no tolerance theoretically, then we decrease the error significantly, right? The tolerance, right? And also heat control, because guide itself is not easy to get the water go into the tip of those drill. I want something very effective internal irrigation drill, so cool down the water, cool down the bone and the drill, so prevent any heat damage, right? And also, again, it's a first related with immediate chest side guide planning. I want something more user-friendly. Dentists is lazy like you and me, right? We do not spend a lot of time to study and practice those software. If possible, I want to have a very user-friendly, very simple and easy software so I can use that software to planning myself, and then sometimes I do the create the prosthesis myself. This is possible, then that really help us, right, in terms of the guide. And then Neobiotech, yes, we have some solution for that. Neobiotech solution is VARO guide. And this VARO guide has some, sorry about that. This VARO guide is basically instead of taking the impression or taking the model or intrascanner from the patient's mouth, we are using the pre-guide, right? Those pre-guide is basically is same as your impression. When you make the impression with the silicone, you are using the pre-guide with the same method, right? Once you create those pre-guide intraorally on your first picture, and then with that we take the CBCT with a pre-guide on it. That's gonna take about 10 minutes. And then all those info go into the very user-friendly software. So especially when you're doing the single molar or single premolar case, right, usually it takes about 10 to 20 minutes, depending on your the learning curve, right? So you can planning it very easily. Then we can send those info to the milling machine that is a VARO mill, and it takes about 7 minutes to create the guide itself, right? And on your right side, you can see those actually milled and then guide, and then you can put this in patient mouth, and then you can do the surgery, right? This is a really breakthrough. And then if you are well experienced, and then you can do this within 1 hour. So when patient comes in and then you took the CBCT, all those procedures can be prepared in 1 hour, and then you're going to the surgery in about 10 minutes, and then usually 1 hour and 1 hour and a half, you can have a CAD/CAM guided surgery with a very high accuracies, right? So Baroga is the big difference, the breakthrough. The main reason that I'm telling you that it's a breakthrough is that it's a zero tolerance, right? You may not believe that, right? So there's a zero tolerance. In other words, since when we take the impression with the silicone patients for the crown and bridge, do we have any gap between tooth and impression? I don't think so, right? There's a little bit elastic over there. So same situation, since we using the pre-guide and then take those, make the guide itself is intraorally, there's no tolerance at all, zero tolerance. And also, when we make those the sleeve, and then instead of using the 3D printing or metal sleeve, actually we are milling it. And then the great point of this, the material, the resin material of the pre-guide is slightly elastic. So what really happens is when we make the sleeve little hole, that hole is slightly smaller than the drill itself. So when the drill goes in, then there is no tolerance at all. But so it is not easy for you to put the drill on it, but once you have a 30 Newton of the motor in it, and then once you spin it, it goes in right in very well, right? And also, important thing is, as I told you before, it is possible to chairside immediate fabrication. So when patient comes in, and then you can do implant surgery in an hour, well, you do it and then let the patient go, and the next day, next afternoon, patient comes in, and then you can do the CAD/CAM surgery. So in terms of the time, I don't have to wait 5 days or 7 days to guide surgery. I can control it. If my patient is really in a hurry, then I can do the express, right? 1 day or 2 day or on that day. If a patient has some time, then I can do a little bit more time and maybe 5 days, 7 days, right? That is a great benefit for the doctors. And also, again, chairside correction and remake is possible. And also, it is we have a user-friendly CAD/CAM softwares, right? That is you can do very easily. So this is I want to share with you on the pictures. This is once your pre-guide is done, ready, then you're going to put those guide on the milling machine like that over here. And then you can just simply push the button, right? So then this milling machine begin to milling the Baro guide, pre-guide. So your pre-guide now become the guide itself by those milling it, right? So this is how it happens. So the machine itself is quite small, right? And then it is quite attractive. And then when I put this in my reception area, and then when those moving, my patients just look at it, they really enjoyed it, right? Like that. So now over here, we are getting end to it. And then now you can see that it creates a hole. So now it ended up, they create the hole. That is the actual sleeve, right? And once they make the sleeve, 99% is done, 100% is done. And then what you need to do is simply, you're going to take this guide from the milling machine, and then you clean it, right? And then you sterilize it, and then you're going to use this to the intraorally, then you can do the surgery, right? So let me show you how to take it out. So simply take it out, unscrew it, and then take those pre-guide, now is a VARO guide itself. Now you can see those little hole. Actually, that is the sleeve itself, created by the milling, right? Now, let me share with you a little bit of the video clip what I mean by the zero tolerance. So on your left, you can see this is a conventional CAD-CAM guide, is CAD-CAM based guide with the metal sleeve on it, right? This one is created using the impression and then extraoral scanning and then create it. But you can see there's a little rocking over there. There's a very minimum, but still a little rocking over there. That little rocking also can have a big error too. But if I'm using the VARO guide, since this VARO guide is intraorally taken and then this one is really fit, there's a very little gap. Once they fit it in, then you can see there's no movement at all. Because those resin is solidified while the photo activated intraorally, so there's a fit right in. How about this? Now I'm going to tell you that there's no gap between drill and the sleeve itself. First, let me share that the uh, drill and sleeve on the conventional guide. So this is a conventional guide, and then I put my drill is in, but you can see that there is a quite a gap, right? That is what I'm talking about, the built-in gap, right? No matter how hard you try, we always has the movement because the tolerance is about 51 micrometers. Then our sleeve is about 3 to 4 millimeter. So we always have the possibility of that error because of the tolerance. However, if you're using the VARO guide, right now I'm going to put it, as you can see, this is quite resistance over there. Then I try to move it, I try to shake it, right? But as you can see, there's no gap, there's no movement at all. I try to move it, but the whole thing is moving, as you can see over here. So this is the breakthrough technology, and this going to decrease, this is decrease those the inaccuracy significantly, right? So nowadays, general consensus is a conventional guide is a safety zone, safety margin is about 2 millimeters, right? However, in the VARO guide, I can tell you is about even 0.5 millimeter is possible. That means when you put the implant, right, then make sure if you're using the conventional, the CAD-CAM system, make sure your implant is at least 2 millimeter away from the bone, right? However, with those VARO guide system, because we increase those accuracy significantly, even 1 millimeter is your enough safety zone. I can tell you that, right? So now I'm going to share a very quick video clip how simple that is in terms of the creating or planning it, right? When you start it, then usually automatically this program giving you those tools, and what you need to do is a tools general the dimension, right? You don't have to be very accurate. Vocal lingual dimension, medial distal dimension on it. Once you have the dimension on it, then get the position as you can see over here. And also I want you to just look at the occlusal line too. And then with that line and then very simplify the program, you can, based on your prosthetic plan, you can place the implant, right? So as much as possible. So if you done this never before, you may have some the time, but usually with a proper education and then with 3 or 4 more times of practice, and then I guarantee with a single case, you're going to finish in 10 minutes because it is very simplified and programmed. If you have a bone graft, sinus elevation, all those things, then yeah, planning takes a little longer, so keep in mind. But my 10-minute planning time is based on our single implant placement planning, right? That is more than enough, right? So this is a quite user-friendly CAD-CAM software. We call that is a VARO plan, right? So VARO guide system has a 3 part. First one is a pre-guide. Second one is VARO mill, right? And also we have a VARO plan. So pre-guide, we made a guide itself, and then VARO plan, that's CAD-CAM system. We do the virtual surgery and virtual restoration. And also with the VARO mill, actually we are milling the guide and we fabricate the guide. The good thing is once the guide is done, sometimes it doesn't fit this rocking. Then all you need to do is you can add the resin and then you can put in patient's mouth and then fix it. That is always possible. Like when you create resin crown or temporary crown, if it doesn't work, then you can add a little bit more of the acrylic or resin. You can make the shape, you can repair it. The VARO guide is exactly the same. So this one is also clinically correctable and repairable. Sometimes you can make it new one right away. That is a great, great aspect of those VARO guide. So hopefully I'd like to see you next week, and then I want to share with you VARO guide step-by-step protocol from A to G next week. Today I show you very little bit of the VARO guide, but next week I'm going to share with you what is the first step, second step, third step, more details. And also once we go over those the protocol, then I'd like to share with you various clinical case using the VARO guide. We start with a single posterior case and then immediate placement, right? So when tooth is already there, but we're using the VARO guide, and how can we make the CAD/CAM guide even before pulling the tooth, right? So we make the pre-guide and then pull out the tooth, and then right after that, we put the implant using the VARO guide within 1 hour. And also I can share with you some case that I use the VARO guide system, the maxillary posterior with the sinus elevation, and also the other couple of the full mouth case too, right? Hopefully I'd like to see you in next week too, all right? So that's it for now. I prepared, and then Gabriel, could you take over?
Okay, yes. Thank you for the lecture, Dr. Park. And now I'm checking any question is popped up, but yeah, I don't see any question yet. So
doctors, do you have any question and the comment? And then please put using those Q&A box, and I can read it right away. Okay, then thank you very much.
Okay. Okay, again, thank you very much for the lecture, Dr. Park. It was a very awesome lecture. We'd like to ask some feedback from attendees about today's webinar. There will be an extra popped up screen with 5 questions, so please share 1 minute for us. Then we're gonna always try the best to improve the quality of webinar for your satisfaction. Those lectures will be uploaded in our website with a YouTube video and sooner or later. Please stay connected with Neobiotech social media service to communicate with us more. Search Neobiotech in Facebook and YouTube, then do like or subscribe to get more information. For the next upcoming webinar will be on 23rd September, next Wednesday, or 8 p.m. on the 22nd day for the Western of the United States time zone. Please check your time zone for local areas. Next webinar will be the second one of the VARO Guide lecture series after today's webinar. If you have any questions or information you need, please contact us by email address or the other SNS service on our website. Don't forget you can get more information from those website or SNS service. Thank you very much for attending our webinar again. We hope all of you enjoyed this time. Please have a good day or have a good night. See all of you again sooner. Thank you.